Today, I will be reviewing maternal complications during the childbearing period, and we'll start with Abruptio Placentae, which is a premature separation of the placenta before the fetus is born, and it occurs when there's bleeding or formation of hematoma, just like we can see on the screen, on the maternal side of the placenta. So again, we said this is separation of a normally implanted placenta before the fetus is born. Most times it occurs with increased blood pressure when there's maternal hypertension, and even you would notice, we'll see this occur with cocaine abuse. And when we assess a client with abruptio placenta, you're going to see painful dark red vaginal bleeding. Again, this bleeding may be scanty, it may be profuse, but again, mark the key word there. With abruptio placenta, there's going to be painful dark red vaginal bleeding. So that's what's going to separate it from, that's one key assessment finding you would see with abruptio placenta. There's going to be painful dark red vaginal bleeding. The abdomen is going to be tender, it will be painful, it will be tense, it could be highly irritable. So the uterus, I mean, or the abdomen. So you're going to see all of these signs. There could also be possible fetal distress. And as a result of the bleeding, the mother may go into maternal shock. You can also notice a low frequent intensity contraction. So the contractions are not intense as they should be. So you have this low frequent intensity contraction. There would also be a high uterine resting tone. One can use our intrauterine pressure catheter to determine this. So if we use our intrauterine pressure catheter, we'll place it into the amniotic space during labor, and it's going to help us to measure the strength of uterine contraction. Remember, the normal resting tone should be between 9 to 12 millimeters of mercury. So additional signs you would see in this client with abruptio placenta would include, if you look at the fetal heart rate patterns, there will be tachycardia or there could be bradycardia. So you'll see all these non-reassuring fetal heart rate patterns. Like we said, there will be signs of hypovolemic shock, especially with the mother. So there could be maternal shock. And it could also lead to fetal death. So let's look at our plan for this client. So in the initial phase, we want to monitor for maternal shock, like we talked about. We want to monitor for fetal distress. And again, the blood loss seen may not match the symptoms. So just because there's not enough or there's not a lot of blood doesn't mean the placenta abruptio is not severe. So you need to take note of that the blood loss seen may not match the symptoms. It could also lead to rapid fetal distress, like we said. So we'll need to prepare for immediate delivery. And one other thing we'll need to watch out for will be to monitor for complications. So there are some major complications that could arise with this condition would be disseminated intravascular coagulation. So with DIC, the blood begins to clot, or blood clot starts to form throughout the body, and these blood clots will start blocking small blood vessels. The client could start presenting with symptoms such as maybe chest pain. So I can assume some of these blood clots are beginning to clot the small vessels in the heart, so that could lead to chest pain. There could be shortness of breath. They could complain of leg pain. They could complain of problems speaking or problems moving parts of the body. So you could also see bleeding gums in this client. And if we try to put an IV line, you will start noticing bleeding around the IV insertion site. So that's one complication you need to look out for, disseminated intravascular coagulation. The client could also come down with a pulmonary emboli. So here you have maybe one or more arteries in the lungs becoming blocked by a blood clot. So we need to look out for that. So you could see, so that would be a pulmonary embolism there. So you can see the blood clot maybe traveling from the leg. So that would be a deep vein thrombosis, and then it goes to lodge within a vessel in the lungs, and that could cause the client to go into pulmonary embolism. Again, we said you are seeing blood clots that are blocking one or more arteries in the lung. Another complication would be infection. The client could also come down with renal failure. Let's look at placenta previa. Again, with placenta previa, the baby's placenta may partially or totally cover the mother's cervix, which is the outlet of the uterus. So again, we know the placenta is, with this condition, the placenta is implanted in the lower uterine segment, usually near or over the cervical opening. So again, there are three major types of placenta previa, and we can use ultrasonography to help us to classify the degree of obstruction. So again, if you look at with type 4, so if this is the cervical opening, you can see the placenta has completely covered the internal cervical opening. So that will be a type 4. So that's a complete placenta previa. With a type 3, you can see there's partial covering of the internal cervical opening. And then with marginal placenta previa, maybe type 1 or type 2, we can see that the placenta is at the edge of the internal cervical opening. So when we assess this client with placenta previa, what are we going to see? We would notice spotting, especially in the first and second trimester. There'll be spotting. In the third trimester, we'll see bleeding that is sudden, painless, profuse, and bright red. So again, you don't want to confuse this with placenta abruptio. With placenta previa, the bleeding is painless. With abruptio, we said it was going to be painful. With placenta previa, we are seeing bright red blood. With abruptio, we said it's going to be dark red blood. So again, that's the distinguishing information you need to know between both of them. What's our plan for this client? We need to hospitalize this client initially, put them on bed rest, or put them in the Trendelenburg box position for at least 72 hours. We need to use an ultrasound to locate the placenta. Let's see where it's lying. If it's a low-lying placenta, we would like to find out. In this period, in the immediate period, there should be no vaginal examination, no rectal examination. And if it becomes necessary, then it must be done in the operating room or under sterile conditions. We would also need to carry out amniocentesis to detect lung maturity. We'll need to monitor this client for changes in bleeding and even the fetal status. We would also need to assess amount of blood loss, assess daily the hemoglobin and the hematocrit levels. We would also need to weigh the client's peripads. Remember, 1 gram is equals to or is equivalent to 1 ml blood loss. Remember that 1 gram is equal to 1 ml blood loss. So for these clients, we'll need to get at least 2 units of cross-match blood available if we need to use it. So we need to get them available. And then we can send the client home if bleeding ceases and the pregnancy is to be maintained. So you want to teach them to limit activity, no douching. So douching would be when they try to use maybe water or other mixtures of fluids to wash out the inside of the vagina. So we need to tell them no douching, no enemas, no coitus. We would also need to monitor the fetal. So you need to assess the mother, assess fetal movement. We can carry out a non-stress test at least every 1 to 2 weeks. we may need to carry out a non-stress test at least every 1 to 2 weeks. So a non-stress test is screening that is used in pregnancies to assess fetal status by means of assessing the fetal heart rate and its responsiveness. So again, we will need to carry out a non-stress test at least every 1 to 2 weeks. And we'll also need to assess for any complications. We might need to deliver by cesarean section. So if there's evidence of fetal maturity, we might need to carry out a CS, or if there's evidence of excessive bleeding, or the mother is going into active labor, or maybe other complications, then we will need to deliver by cesarean section. With cardiac disease during pregnancy, remember cardiac disease is one of the leading causes of maternal mortality. And clients who present with cardiac disease during pregnancy will complain of chest pain, they'll complain of difficulty breathing on exertion, and even when they're at rest, they still have this difficulty breathing. So you're going to see dyspnea on exertion, dyspnea at rest. And our plan for this client will be to encourage rest, encourage adequate nutrition during pregnancy. We want to assess maternal vital signs and fetal heart rate frequently. So you want to place the mother on a cardiac monitor. You can also place her on an external fetal monitor so that we have those informations on the fetal heart rate and the maternal vital signs. We also want to encourage moderation in physical activity. Again, she's already having dyspnea at rest. So you want to encourage moderation in physical activity. And we want to assess activity level during labor. We want to provide emotional support. And you also want to be alert for signs of heart failure in this client. Is the dyspnea increasing? Is there tachycardia? Is there weight gain? So again, all of those will point us to signs of a heart failure. So that increased dyspnea, the tachycardia, the weight gain. We want to maintain bed rest with mother inside lying or in semi-recumbent position. We want to administer oxygen as prescribed. Remember, because of that difficulty breathing on exertion and at rest. So we want to administer oxygen. And again, you want to assess for signs of pulmonary edema. So with pulmonary edema, there's going to be excess fluids building up in the lungs. The client is going to complain of dizziness, feeling weak or lightheaded, shortness of breath, having difficulty breathing, wheezing, or even gasping. So we need to assess for signs of pulmonary edema in this client. Let's look at cesarean section. So here you are carrying out an incision in the mother's abdomen and delivering a baby. So that will be CS. But again, what are indications for cesarean section? So again, like on our screen, you can see an umbilical cord prolapse would be one indication for cesarean section. So again, this happens when the umbilical cord slips down in front of the baby after the water has broken. And again, you can see where the cord is lying, and you can see the head is up there. So again, this head can even cause a cord compression. So how do we know when there are signs of umbilical cord compression? You will notice less activity from the baby. So there will be decrease in movement. The heart rate can become irregular. So again, if this baby is connected, if this fetus is connected to a fetal heart monitor, we can see those signs of umbilical cord prolapse umbilical cord compression. Another indication for cesarean section would be cephalopelvic disproportion, where the baby's head is too large to fit through the mother's pelvis. So again, when the baby is too large, it becomes challenging, if not impossible, for the baby to be delivered vaginally. What could cause the baby, what could cause a CPD, or what risk factors would there be that could lead to CPD? Gestational diabetes. Remember, that could make the baby to be big if the client has a narrow pelvis, or if it's a post-term fetus, that could also lead to CPD. Again, there are also warning signs of CPD. If the labor is prolonged, or when there's failure to progress. Remember, prolonged labor is characterized by when the labor lasts 18 to 24 hours after regular contractions begin. So other warning signs of CPD would be fetal distress in the client, maybe if there are high levels of amniotic fluid, what we refer to as polyhydramnios. Again, too much amniotic fluid is going to cause the uterus to become larger than average. If you notice a large fundal height measurement, that could also be a warning sign of CPD. And we also need to be cognizant of complications that can arise with cephalopelvic disproportion. One would be cerebral palsy. There could also be hypoxic brain damage. There could also be shoulder dystocia. Another indication for cesarean section would be placenta abruptio. We already spoke about that. Another indication could be your fetal malpresentation. So this refers to a fetus with a fetal part other than the head that's engaging in the maternal pelvis. So again, that could be another indication for CS. We already talked about placenta previa. That could also be another indication for cesarean delivery. Other indications would include if there's a non-reassuring fetal heart rate tracing, or the client has uterine rupture, or in cases of severe PreEclampsia, or multiple gestation of 3 or more babies. Again, with HIV that's untreated, or if the client has high viral load, we might need to carry out cesarean delivery. Maybe late-term or active genital herpes infection, that would also cause us to carry out cesarean delivery, or even in cases of uncontrolled diabetes. So these are indications for cesarean section. Again, cesarean section may be a vertical incision or a transverse incision. So what's our plan for a client for cesarean delivery? We'll need to obtain lab tests, carry out typing and cross-matching. We want to carry out urinalysis, do a CBC, and we'll need to provide routine preoperative care, give your IV fluids. We'll need to insert an indwelling catheter. We'll need to provide emotional support, especially if the mother, if this is her first time. So again, we want to provide emotional support for her as a new mother and also as a surgical client. We'll need to administer preoperative medications. Usually, lower narcotic doses will be required than the routine preoperative medication because of the fetus. So again, we'll be using lower narcotic doses. We'll need to provide routine post-op care. So again, in the post-op period, you want to monitor for hemorrhage. You want to assess the fundus for firmness and location. If it's boggy, you want to massage the uterus. You want to assess the skin incision area and dressing for signs of excessive bleeding. You want to assess vital signs for evidence of shock. We also need to provide comfort measures and medications to control pain in our client. You want to teach the client to splint the incision area when the client is carrying out deep breathing exercises. You want to give the mother her infant. Again, this is going to help to promote bonding between the child and the mother. And we would also need to encourage ambulation in this client. Let's quickly look at ectopic pregnancy. Here, there's a pregnancy in which the fertilized egg implants outside the uterus. Again, we know that the fertilized egg can survive outside the uterus, and if it's left to grow, it's going to damage nearby organs. It can cause life-threatening blood loss. What could cause the fertilized egg to go and implant outside of the uterus? If your client has a pelvic inflammatory disease, that could cause it. If there's previous tubal surgery, that could obstruct and cause the fertilized egg to implant in the tubes, or maybe a congenital anomaly of the fallopian tube, that again can also cause that. So again, what are we going to see in this client with ectopic pregnancy? They're going to complain of a missed period. You would also see unilateral lower quadrant pain. You know, they've been pregnant, and maybe after 4 to 6 weeks, they now start complaining of this one-sided lower quadrant pain. Their abdomen may be rigid, it will be tender. So again, you're going to see referred shoulder pain in this client. And this can occur because in the later stages of ectopic pregnancy, the fallopian tubes can rupture. And that internal blood will now start collecting under the diaphragm. And this is going to lead to nerve irritation. As a result, you're going to see pain in the shoulder and pain in the neck. What else are you going to see in this client? We're going to see low hematocrits. We're going to see low HCG levels in the urine and in the blood. And again, you're going to see gradual oozing of blood to frank bleeding in this client. So again, the bleeding is going to be gradual oozing, and it can progress to frank bleeding. Our plan for this client would include preparing for surgery. We want to monitor for shock preoperatively and even postoperatively. We want to provide emotional support for this client. We want to help them to express their grief. We would also need to administer ROGAM, your ROD immune globulin, especially if the woman is ROH negative. So again, we want to monitor. So remember with ROH negative mother, if the father is ROH positive and the child is like the father and has ROH positive, we need to give ROGAM because this mother has no ROH positive antibodies. And we need to keep it that way. If not, if we allow the ROH positive to cross over, it's going to sensitize the mother. And as such, any other pregnancy is going to be affected because now the mother has been sensitized and she would have developed ROH positive antibodies. So again, we want to give ROGAM IM at 28 weeks gestation and within 72 hours after delivery. So again, you want to take note of that. ROGAM should be given IM at 28 weeks gestation and within 72 hours after delivery for your ROH negative mother. Again, we would also need to teach carry out discharge teaching for this client. With induction of labor, there's a process of artificially stimulating the uterus to start labor. So you are starting labor artificially. We can do this by administering oxytocin to the pregnant woman, or we can manually rupture the amniotic membranes, and this is also going to help to start labor. So we can carry out maybe using an amniotic forceps to rupture the amniotic membrane to artificially stimulate the uterus to start labor. What are indications for induction of labor? If our client is diabetic, post-maturity, gestational hypertension, or fetal jeopardy, so again, or fetal danger. So maybe if there's prolonged fetal bradycardia, we're looking at the fetal monitor and we are seeing repetitive late deceleration. So you see a fall in the fetal heart rate that begins at the peak of the uterine contraction, or it begins after the peak of the uterine contractions, and then it returns to the baseline only when the contraction has ended. So that would be a non-reassuring sign. So again, that could be an indication for induction of labor. As part of our plan, we want to assess the fetus continuously by external monitor. So we need to connect the mother and we'll need to keep monitoring the fetus. We'll need to monitor the blood pressure, the pulse, and the progress of labor of the mother. We'll need to prepare for amniotomy, so that will be rupture of membranes. We need to begin oxytocin administration. And when we are giving oxytocin, we want to piggyback it to our principal IV line. So again, so there's our oxytocin, and we want to piggyback it to our main IV line. So again, this is going to help to reduce multiple IV sticks on your patient. So again, We also need to administer this with an infusion pump. So you want to connect your oxytocin to an infusion pump. And while you're at it, you want to monitor the contraction pattern. Remember, normally you should have at least every 2 to 3 minutes. So that should be your contraction pattern every 2 to 3 minutes, lasting for 90 seconds or less. So remember that for the NCLEX, contraction patterns every 2 to 3 minutes, lasting for 90 seconds or less. And we'll need to stop the infusion if fetal distress begins, or you notice fetal distress, or we notice hypertonic contractions. So this would be contractions that last more than 90 seconds, or contractions that occur more frequently than every 2 minutes. So again, remember we said we want our contraction pattern should be between 2 to 3 minutes, and it should last 90 seconds or less. So again, you want to immediately stop that infusion if fetal distress develops, or you start seeing contractions that are lasting more than 90 seconds, or they are occurring more than every 2 minutes. So again, that will be what you do first before you call the healthcare provider. With preterm labor, this is labor that begins early, before 37 weeks of pregnancy. And this can lead to premature birth of the baby. So premature birth is when your baby is born early, before 37 weeks of pregnancy. So with preterm labor, you're going to start seeing regular contractions that result in the opening of the cervix. Again, we said before 37 weeks of pregnancy. What are the risk factors that can put a client at risk for preterm labor? Being of African American descent, older than 35 years, or the client is younger than 17 years, low socioeconomic status, previous preterm labor or birth, any medical disease, smoking or substance abuse, problems with pregnancies. Again, what are the warning signs of preterm labor? What are you going to see that would give you an indication your client may be going into preterm labor? They will start complaining of backache, will start noticing contractions, you will see cramping, and then there will be fluid leaking. What's our plan for this client? We want to place them on bed rest in the side lying position. We want to carry out monitoring or uterine monitoring, daily weights. We want to maintain good nutrition. We'll need to administer medications, carry out relaxation techniques. And some of the medications we might need to administer would be our terbutaline. Remember, terbutaline is given only subcutaneously. So again, you can see on the screen, terbutaline is for subcutaneous use only. It helps to prevent and slow contractions of the uterus. Terbutaline can also help to delay birth for several hours or days. So again, it's a subcutaneous route medication, and dose is between 0.25 milligram subcutaneously every 1 to 4 hours for at least 24 hours. So again, we're going to administer terbutaline because it's going to help to prevent contraction. It's going to help to slow contractions. It's going to help to delay birth for at least several hours or days. With postpartum depression, is depression that occurs after childbirth, and it's usually associated with changing hormone levels. So usually you would see a decrease in estrogen and progesterone, and this can precipitate what we call baby blues or postpartum depression. And it occurs during the first year, often by the 4th week. So that's when your client can start developing postpartum depression during the first year, and often by the 4th week. So you're going to see sadness and crying in this client. There's difficulty concentrating. They would complain of being fatigued. There will be appetite and sleep disturbances in this client. So what's our plan for a client with postpartum depression? We need to encourage verbalization of feelings. You need to identify their concerns. You also need to assess for potential for suicide in this client. It's very important. There could be suicidal tendencies with this client. You want to consult with the medical and the psychiatric staff. We need to bring in support groups. We'll need to administer medications, your antidepressants. So one of them would be Elavil or your Zoloft. And we'll need to assist with care of the baby. So again, that was part of our plan for this client. With postpartum infection, this occurs when bacteria infects the uterus and the surrounding area after a woman gives birth. So that will be postpartum infection. So you're looking out for a temperature of 104 degrees or higher on any 2 consecutive postpartum days. So again, this is exclusive of the first 24 hours. So again, it's normal after delivery for we to see some increase in temperature or above normal within the first 24 hours of delivery. Again, this could be as a result of dehydration. It could be as a result of the stress of the labor process. So again, that would be expected on the NCLEX if within 24 hours there is an increase in temperature. But if after 24 hours, we are seeing an increase in temperature of 38 degrees or higher on any 2 consecutive postpartum days. So again, she has delivered, it's been 24 hours, there's 38 degrees on Monday. The next consecutive day will be Tuesday, and it's still at 38 degrees. Then we should be suspecting postpartum infection. Again, we would also see chills. The heart rate will be increased. The client would complain of abdominal pain or severe after pains. There will be perineal discomfort. If we look at the lochia, there will be foul odor, or the rubral phase may be prolonged, or there could even be a decreased amount or maybe increased amount. And then we would also assess for localized tenderness. So these are what you'll be looking out for in your client with postpartum infection. So we can carry out diagnostic tests like your blood cultures, urine culture. Again, you also need to look at the white blood cell count. So look out for a significant increase over a 6-hour time period. So it's again very vital. We're looking at the WBC count for a significant increase over a 6-hour period. What's our plan for this client? We need to encourage early ambulation. We need to change peri-pads frequently. We need to provide adequate nutrition, fluid intake, and sleep. We would also need to monitor for signs of infection in this client. And again, we'll need to administer antibiotics if ordered. With postpartum hemorrhage, so this would be blood loss greater than 500 ml after a vaginal birth, or greater than 1,000 ml after a cesarean birth. So blood loss 500 ml after vaginal delivery, that's postpartum hemorrhage. If the mother had a C-section and we have a blood loss greater than 1,000 ml, that is postpartum hemorrhage. So with these clients, there will be a history of maybe the mother is multiparous, there may be a history of retained placental fragments, or the uterus was overdistended, or there was prolonged labor, or maybe the infant that was delivered was large. So you would notice that history in clients with postpartum hemorrhage. As part of our assessment, we need to carry out accurate measurement of blood loss, and that could be accomplished by weighing the peri-pads. So it could be graduated into moderate blood loss, where if within 1 hour we have between 25 to 50 ml, so that will be categorized as a moderate amount. It could be large if the blood loss on the peri-pad within 1 hour is between 50 to 80 ml. So again, we are assessing the blood loss in 1 hour. We are weighing the peri-pads. 25 to 50 ml will be categorized as moderate, and large blood loss will be 50 to 80 ml within a 1 hour period. Again, part of your assessment would be looking at the lochia, because you could notice the lochia might be regressing to a previous stage. So again, we know that in the first 1 to 3 days, we should be having lochia rubra, which is red in color, composed of blood, fragments of the decidual, mucus, and all of that. Again, this should be within 1 to 3 days. And it should proceed to lochia serosa, which is pink. and this should last for between 3 to 10 days. So again, it composes of blood, mucus, and leukocytes, and then it should progress to local alba, which is whitish, and this should last between 10 to 14 days, and it's more of mucus. So again, if we notice that initially we had local alba, which was white, and then it's becoming pinkish, it's regressing to a previous stage, that could also be a sign of postpartum hemorrhage. So you need to take note of that on the NCLEX. As part of our plan, we'll need to massage the uterus post-delivery if it's not firm. So if it's boggy, you need to massage the uterus. We'll need to assess involution for early identification of problems. We'll need to administer oxytocin. We'll need to give ergonovine. This is going to help to control postpartum hemorrhage. Again, remember, with these medications, some adverse effects can arise, such as hypertension. So again, with these medications, the client can become hypertensive. There could be GIT, adverse effects like nausea and vomiting. So you need to take note of that for the NCLEX. We also need to monitor for signs of shock in this client. Let's look at a precipitous delivery outside the hospital setting. So again, this could also be called rapid labor, and is defined as giving birth after less than 3 hours of regular contraction. So that's what they refer to as precipitous. So again, our plan would be to remain with the client, prepare a sterile or clean environment. You want to support the infant's head. You want to apply slight pressure to control that precipitous delivery, that rapid labor. You also want to slip a nuchal cord if it's present over the head. So again, if we have a nuchal cord over the around the neck, we want to slip that out. So to prevent any complication, we want to rotate the infant externally as the head emerges, and then we want to deliver the shoulders and the trunk. Remember to dry the baby and place the infant on the mother's abdomen. Hold the placenta as it's being delivered. Wrap the baby in a blanket, put them to breast. Check for bleeding. Check for fundal tone. And then we want to arrange transport to the hospital. And on that route, we're going to be supporting the mother and the family. Let's look at gestational trophoblastic disease, or our Hydatidiform mole. So again, this would be growth of abnormal fertilized eggs or an overgrowth of tissue from the placenta. So in clients with Hydatidiform mole, they would appear to be pregnant, but the uterus enlarges much more rapidly than in a normal pregnancy. What are you going to see with these clients is they're going to have elevated HCG levels, more than normal. Uterine size will be greater than expected for their dates. There will be no fetal heart rate. You will notice minimal dark red or brown vaginal bleeding with passage of these grape-like clusters. So again, like we said, if we use an ultrasound, we're not going to see any fetus. The client would also have increased nausea, vomiting, and they usually have very high blood pressures. What will be our plan for this client? We might need to carry out curettage to completely remove all of this molar tissue. Remember, this tissue can become malignant, so we'll need to take them all out. Pregnancy is discouraged for 1 year. You want to advise use of oral contraceptives. Where these clients with Hydatidiform mode, we don't advise use of IUD because this is to avoid uterine perforation and subsequent bleeding. So again, we advise them to go with oral contraceptives, not IUD, because we're trying to avoid uterine perforation and bleeding. We're also going to be monitoring HCG levels for at least a year. So your HCG, which is your human chorionic gonadotrophin, is a hormone that is produced by the placenta once an embryo implants in the uterus. So we're going to be monitoring to see if it continues to be elevated. And if it does, it may require hysterectomy and chemotherapy. Again, we'll need to discuss contraception with this client, like I already mentioned. And we'll need to administer Rho-D immune globulin to the mother if she's ROH negative. Again, this would help to prevent isoimmunization in the mother who is ROHD negative. Let's quickly look at hypertension, preeclampsia, and eclampsia. So these would be potentially dangerous pregnancy complications that can arise and is characterized by high blood pressure. It could be a pre-existing hypertension in the mother. So again, this would be a blood pressure of above maybe 150 millimeter over 90 and above. And usually you could notice this at booking, maybe before 20 weeks or maybe in the pre-pregnancy period. So that would be your pre-existing hypertension. With gestational hypertension, this is going to be characterized by blood pressure of 140 over 90 or higher. But again, you don't see protein in their urine. Again, this could resolve by 12 weeks postpartum. So again, gestational hypertension will be characterized by high blood pressure without protein in the urine after 20 weeks gestation. We can also have preeclampsia or eclampsia. Again, these are pregnancy-related high blood pressure disorders. With preeclampsia, there's a sudden spike in the blood pressure. With eclampsia, it's more severe, and it can even lead to seizures or coma. So what are risk factors that can place a client at risk for preeclampsia or eclampsia? Being African-American descent, a primate who is older than 35 years or younger than 17 years, a client with multiple fetuses, if there's a history of renal disease, family history of hypertension in previous pregnancies. So these are risk factors that can place a client at risk for preeclampsia. So what are the characteristics of preeclampsia and eclampsia? So with mild preeclampsia, like we said, you're going to see blood pressure greater than 140 over 90 after 20 weeks gestation. And there will be protein in the urine. So we could see up to 300 milligrams per liter per 24 hours. And it will be greater than 1 plus in a random sample. So again, we're going to see protein in the urea, but there will be no seizures, no hyperreflexia. There could be mild facial swelling, mild weight gain, greater than 4.5 pounds per week. So that's also another sign that your client may be going into preeclampsia when you start noticing weight gain greater than 4.5 pounds per week. With severe preeclampsia and eclampsia, the blood pressure is going to skyrocket above 160 over 110 millimeters of mercury. With proteinuria, it will be greater than 500 milligrams per liter per 24 hours, and it will be greater than 3 pluses in a random sampling. So that's with severe preeclampsia. But with eclampsia, there will be marked proteinuria. It will be obvious, it will be significant. With seizures, there are no seizures with severe preeclampsia, but again, there will be hyperreflexia. Whereas with eclampsia, there would obviously be seizures, but there will be no hyperreflexia. So what other symptoms we would see? So with severe preeclampsia, client will complain of headache, there will be oliguria, there will be blurred vision, they will complain of right upper quadrant pain. You would also see thrombocytopenia, where the blood platelets become low. And they could also develop HELLP syndrome. So that would be hemolysis, E for elevated liver enzymes, LP for low platelet counts. So again, this would be a constellation of signs where you see hemolysis, elevated liver enzymes, and low platelets. Whereas with eclampsia, other symptoms we would see would be those same as the severe preeclampsia. The headache this time around would be severe. They could go into renal failure. They could also go into cerebral hemorrhaging. So again, let's talk about the treatments for these condition. So with mild preeclampsia, we might need to place them on bed rest in the left lateral position, carry out frequent follow-ups. With severe preeclampsia, the treatment is going to depend on the fetal age, and the only cure is to deliver the fetus. So we need to deliver the fetus. We need to carry out induction of labor and deliver the fetus. We will need to control that blood pressure that is above 160/110. So we can give hydralazine. We will need to prevent seizures. So that's where your magnesium sulfate comes in. So again, we want to prevent seizures. So we'll need to give Maxolf. Again, we'll need to provide emotional support, especially if the delivery is prior to the age of viability of the fetus. So you want to provide that emotional support. And again, we'll need to carry out DIC management for this client. With eclampsia, this is more of a medical emergency. So we're going to support the patient through those seizures. Remember, we said there's going to be seizures and potential coma. So we're going to support this patient. We ensure a patent airway. We want to give oxygen. We want to carry out DIC management. We want to carry out delivery of the fetus. We will need to provide emotional support, especially, like we said, if the delivery is prior to the age of viability. And in cases of severe hypertension, you need to remember that seizures may still occur 24 to 48 hours postpartum. You also want to monitor magnesium sulfate or our hydralazine if this continues postpartum. So I know we've mentioned DIC management. So again, DIC, which is your disseminated intravascular coagulation, is a condition in which blood clots form throughout the body, and they'll just go about blocking small blood vessels. DIC is seen in severe forms of preeclampsia, where the client developed this HELLP syndrome that we talked about, and they will start complaining of chest pain, shortness of breath, problem speaking, leg pain, or problems moving body parts. So in terms of treatment, the goal is to treat the underlying cause and to provide supportive care, maybe by giving IV fluid, by giving blood transfusion, by trying to control severe bleeding. Remember, we said the platelets will be low. So again, we talked about HELLP syndrome, and we said HELLP means hemolysis, there will be elevated liver enzymes, and there will be low blood platelet counts. Again, this is a serious complication of high blood pressure during pregnancy, and it usually develops before the 37th week of pregnancy. And we already talked about the symptoms. We said there could be nausea, headache, stomach pain, swelling, and it can cause severe itching in pregnancy. So treatment usually requires delivery of the baby, even if the baby is premature. Let's look at spontaneous abortion. So this will be termination of pregnancy spontaneously at any time before the fetus has attained viability. And it could be caused by chromosomal abnormalities, teratogenic drugs, or even abnormalities of the female reproductive tract. When you assess this client, there's going to be persistent uterine bleeding. They will complain of a cramp-like pain. Our laboratory findings will be negative or weakly positive in our urine sample tests. When we carry out urine pregnancy tests, we need to obtain the client history, including their last menstrual period. Again, we could classify abortion as threatened. Here, there will be vaginal bleeding. There will be vaginal bleeding and cramping. The uterus will be soft. The cervix will remain closed. So again, that's for our threatened abortion. Part of our nursing consideration will be to carry out ultrasound for intrauterine sac, carry out a quantitative HCG assessment. We want to decrease client activity for 24 to 48 hours, avoid stress, no sexual intercourse for 2 weeks after bleeding stops. We also need to monitor the amount and character of bleeding. We need to report any clots, any tissue, any foul odor. Again, it could be an inevitable abortion. Here, cervical dilatation cannot be prevented. So the clients, as part of our assessment, will present with persistent symptoms, bleeding, moderate to severe cramping. There will already be cervical dilatation and effacement. So part of our nursing consideration would be to monitor for hemorrhage. You want to save and count the pads, monitor for infection. If it's persistent or there is increased symptoms, we'll need to carry out D&C. Again, you'll need to provide that emotional support for grief and loss. With incomplete abortion, there will be persistent symptoms, but there will be expulsion of parts of products of consumption, not all of it. So it will be incomplete. For this, we'll need to administer IV, give blood, give oxytocin. We need to carry out D&C or carry out suction evacuation. Whereas with complete, same as above, except that there will be no retained tissue. Remember, this was here we saw expulsion of parts of products of conception, but with complete abortion, there's no retained tissue. Part of our management would be to give methyl egonovine. There will be no other treatment required if there's no evidence of hemorrhage or infection. With a missed abortion, here the fetus dies in the utero, but it's not expelled. So there may be no signs or no symptoms, or there may be some abating of those symptoms. Here the cervix is closed. If it's retained greater than 6 weeks, there's increased risk of infection, there's increased risk of DIC and emotional distress. For a missed abortion, we'll need to carry out D&C evacuation within 4 to 6 weeks. After 12 weeks, we'll need to dilate the cervix with several applications of prostaglandin gel or suppositories of laminaria. So these are dried, sterilized seaweeds that expands with cervical secretions. It could also be habitual, where you have 3 or more abortions, maybe due to incompetent cervix. It could lead to infertility. We'll need to carry out cerclage. So again, with cerclage, there will be encircling the cervix, so using sutures to try to keep the cervix closed. So part of our plan would be to monitor the vital signs, monitor for bleeding, cramping, for those pain, monitor hydration status and electrolyte levels, administer ROD, save all tissues. We want to teach purpose of bed rest. We want to prepare the client for surgical procedure if it's going to be indicated, maybe a D&C or a therapeutic abortion. And as usual, we'll need to provide emotional support for grief and loss. Finally, let's look at diabetes, which is a disorder in which the body does not produce enough or respond normally to insulin. This is going to cause the blood glucose to be abnormally high. It could be a type 1 diabetes, which is a more common complication, or it could be a type 2 diabetes, or it could be gestational diabetes, which we already talked about, where there's increased demand for insulin during pregnancy. Here you see impaired fasting glucose tolerance as part of our findings with this client. So let's look at our findings, our assessment, and what we should be looking out for. We'll need to carry out urine screening for ketones. So remember, normally your body burns glucose for energy. So if your cells don't get enough glucose, they start to burn fat for energy. And when they burn fat for energy, it is going to produce a substance called ketones. And these ketones can show up in your blood and your urine. So again, we need to assess for ketones in the urine. We need to assess the blood glucose levels. We need to carry out glucose tolerance test. So with glucose tolerance test, glucose is given and blood samples are taken afterwards to determine how quickly it is cleared from the blood. So we could take in the morning, we can do a blood test when the patient has not had anything to eat or drink for at least 8 to 10 hours, and then we'll give them a glucose drink. We'll have them to rest for like 2 hours, and then another blood sample is taken to see how well the body is dealing with the glucose. And it's usually done between 24 to 28 weeks for women at average risk. So if a woman is at high risk for an average risk for diabetes, maybe they are 25 years or older, or they are obese, or there's a family history of diabetes, or there's a history of abnormal glucose tolerance, then we can carry out this test between at 24 to 28 weeks. We would also need to carry out glycosylated hemoglobin, which is your HbA1c. And this actually tries to assess your serum glucose level over the previous 3 months. So again, we're looking back at how your serum glucose level has been in the last 3 months, and the normal range should be between 3.5 to 6. Again, diabetes increases risk for maternal infections like your UTIs and vaginal yeast infections. It increases risk for hypertensive states of pregnancy, for hydramnios. So hydramnios occurs when there's too much amniotic fluid, which builds up during pregnancy, greater than 2,000 ml. And this can lead to consequent preterm labor. So again, diabetes also increases the risk for macrosomia, which would be enlarged for gestational age, even though they may have immature organ system. It could also lead to congenital abnormalities like your neural tube defects. It could lead to prematurity and stillbirth. It could lead to respiratory distress syndrome. And if it's untreated, it could lead to ketoacidosis that can cause coma and death of the mother and the fetus. So just to throw more light on gestational diabetes, so remember that there's high blood glucose levels in the mother, which is going to lead to extra glucose to the baby, and then the baby is going to be born with extra weight gain. So again, here you see hyperglycemia after 20 weeks when insulin needs increases, but this could be controlled by diet. For the NCLEX, you need to take note that oral hypoglycemics are not used. Your oral hypoglycemics are tetranogenic, they are teratogenic, and they can increase risks of neonatal hypoglycemia. That's why we don't use oral hypoglycemics with gestational diabetes. What are risk factors? We already talked about that. History of family, history of diabetes, obesity, history of gestational diabetes. Those are blood pressure conditions, your hypertension, preeclampsia, recurrent UTIs, monoleal vaginitis, even polyhydramnios. So polyhydramnios would be to have too much amniotic fluid around the baby during pregnancy. Previously unexplained death or anomaly or stillbirths, glycosuria, proteinuria on 2 or more occasions. So these are risk factors for gestational diabetes. So with these clients, we'll be testing for diabetes at 24 to 28 weeks for all gravidas. We'll need to screen blood glucose level 1 hour after 50-gram concentrated glucose solution. Then at 3 hours, we need to carry out another glucose tolerance test. And what are the normal findings? So our fasting blood sugar should be less than 92 milligram per DL. After 1 hour, it should be less than 180 milligram per DL. After 2 hours, it should be less than 153 milligram per DL. After 3 hours, it should be less than 140 milligram per DL. So if we have 2 or more abnormal findings, then that's significant for diabetes. Again, we're going to give 50 grams of concentrated glucose solution. And then these are the findings we should have after 3 hours. So again, you can pause the video to go through these numbers. We'll need to also carry out glycosylated hemoglobin, which we said is our HbA1c. And we said it measures blood glucose in the past 3 months. So if it's elevated or if it's greater than 6 in the first trimester, it's associated with increased risks of congenital anomalies and even spontaneous abortion. If it's elevated in the last trimester, you could see macrosomia. So again, macrosomia would be when a baby has been diagnosed as having, or the weight is more than 8 pounds, regardless of his or her gestational age. So again, that's what you're going to see with if we have elevations with the HbA1c in the last trimester. As part of our plan, we want to reinforce the need for careful monitoring throughout pregnancy, including frequent evaluations. We want to evaluate the client's understanding of medications in their diet and insulin. You want to teach the client and at least one significant other person about their diet, about home glucose monitoring, and even insulin use. Why are we giving insulin? What's the dosage? What's the administration route? What are their actions? What are adverse effects? And how potential changes in amount will be required during pregnancy as the fetus grows and even immediately after delivery. Again, you must reiterate that no oral hypoglycemic should be given because it is teratogenic. We'll need to assist this client with stress reduction, and we'll need to carry out fetal surveillance.